Hello everybody, welcome on this webinar. I'm Stephen de Koning, I'm your host for today. I'm the chairman of the European Teaching Group of Orthopedic Medicine, and together with my international teaching team, we offer continuing education projects in musculoskeletal medicine all over the world. Just check out the website syriax.eu to find out more about the different cities in which we offer those courses. This webinar is broadcasted live from the Edgom Training Center here in De Haan along the beautiful Belgian coast. This is the place to be. This is the place where we offer the mastermind training in orthopedic medicine, a very special private training, 7 days intensive training for maximum 4 participants. Check out the website and find out all the details about this specific training. But before we go to the actual webinar, the topic from today, I would like to invite you to join our scientific Facebook group, OMC Modern Orthopedic Medicine Network. On this Facebook group we focus on interesting scientific information, some interesting discussions. Please join the group and get inspired. And for those of you who didn't download yet the free ebook on clinical reasoning, 156 pages practical information on clinical reasoning, diagnosis and differential diagnosis, well, do it today. Yeah, surf to syriax.eu and get your free ebook today. If you want some more information, where there are different ways where you can find information about orthopedic medicine, the main website syriax.eu, there you find everything you need to know about the international program. On learnorthopedicmedicine.com you find everything you need to know about online training, how you can study at your own home. syriaxcourses.com, there you find everything you need to know about the mastermind private training and the special Reboost course. And of course we have some more partner websites, Spanish information for Latin America, information for Southeast Asia, information specifically in Chinese for Taiwan and China, for the Polish area and also for the Slovenian area. So let's move on to the topic of today's webinar. Well, today's webinar is going to be presented in a nice film where you're going to get some specific inspiration on today's topic. So enjoy and see you later. So we did a functional examination, remember, once in a while an active test, but mostly passive test and resisted test. Yeah, passive test, we test pain, range of motion and feel. Resisted test, pain, weakness. We have a cluster of positive signs and negative signs, but now the question is, how do you have to interpret that? Well, when do we have a lesion of an inert structure? In every situation where one or more passive tests are positive and your resisted tests are negative, then we have an inert lesion. But then the question is, which inert structure? And there is something typical Syriax again. Syriax divided the inert structures in two groups. On the one hand, the capsule. On the other hand, all the rest. Disc, menisc, bursa, nerve, ligament, and so on. If there is a problem with the capsule, you're going to find in the examination a capsular pattern. And what is a capsular pattern? Well, each joint which is under muscular control has a specific capsular pattern. Let me give you an example. The capsular pattern in the elbow, limitation of flexion and extension, but flexion is more limited than extension. In the knee we have something similar. Flexion is more limited than extension. The shoulder, for instance, you have a limitation of lateral rotation, abduction, medial rotation, but lateral rotation is more limited than abduction, and abduction is more limited than medial rotation. It's about the relation between the movements. You could have small limitation, medium limitation, big limitation, but the relation is important. That's something that Cyriax discovered, during his discovery time, so to speak. Fortunately, there's also quite some research on that topic, but I discuss all those items during the live training program. But I can already tell you now that the capsular pattern in the shoulder seems to be very valid. Has a kappa factor or 0.87, if I'm not mistaken. The capsular pattern in the knee, there is some confusion depending on the situation. Capsular pattern of the hip, as originally described by Cyriax, well, during the years we modified that capsular pattern because the original version didn't seem to be that valid. But okay, as I told you, more information about science during the live courses. But what's the consequence of a capsular pattern? Well, if you find a capsular pattern in the examination, the diagnosis is simple, or the problem is arthrosis or arthritis. So you never come to this conclusion based on medical imaging. It's the functional examination that tells you. It's perfectly possible that you see an X-ray with an arthrotic shoulder, but the patient has a chronic bursitis. Yeah? So don't focus on the arthrosis you see on medical imaging. Focus on the function of the patient. And how do we make the distinction between the two? Well, arthrosis, there you're going to have a hard end feel on passive movement testing. And with arthritis, of course, this is an acute active lesion, you're going to have a muscle spasm end feel. In acute cases, the capsular pattern is the result of a protective muscle spasm mechanism. In chronic cases, you really have a structural problem. We have a problem with adhesive, let's say, non-elastic scar tissue. So you can already imagine that in an acute case, the treatment is going to be totally different than in a chronic case. But more about that in some other films. Everything which is not a capsular pattern, so that's something you have to study by heart, all the capsular patterns of the different joints. Everything which is not a capsular pattern automatically is a non-capsular pattern. And what is a diagnostic interpretation? Well, there are numerous options, but that could be, for instance, ligamentous adhesions, a chronic ligamentous lesion. Could be internal derangement. Internal derangement is very frequent in the spine, sometimes also in the extremities. Could be an acute muscle belly lesion, could be a chronic bursitis, could be an acute bursitis. Those are things we discuss during this online course and during the... Okay, when do we have a lesion of a contractile structure? When one or more resisted tests are positive. And my first idea, of course, is some kind of muscle belly or a tenderness lesion. Yeah? The ideal situation is that one resisted test is painful, the passive tests are negative, then you think of a contractile structure. But there are many muscles which have a double function. So it's very likely that you find two positive resisted tests. For instance, hamstrings lesion, biceps femoris. What are you going to find? Resisted knee flexion is painful, but also resisted lateral rotation. If you think of pes anserinus, resisted flexion, resisted medial rotation. No problem. The moment you find 3 positive resisted tests in your examination, then theoretically you could think of a double muscle lesion, but this is not very likely. Of course, after a sports trauma, everything is possible. Keep it in mind, but it's not a top of the bill lesion. And as I mentioned before, as from 4 positive resisted tests, your first idea is not a muscular idea anymore. This is quite an example of an inherent unlikelihood. So you don't expect a real contractile lesion. Perhaps there is a link to hypersensitivity, psychogenic patient, or heavy pathology. We're talking about tenderness lesions. If you ask me what is the reason for a tenderness lesion, what's the mechanism behind it, well, then the only honest answer is going to be we don't know exactly. There are certain hypotheses, and I honestly think it's a combination of elements that plays a role. But what is the main trigger factor? That's difficult to pinpoint. Keep in mind this: if you have an acute tenderness problem, a very nice acute tendinitis, in comparison to a chronic tendinosis, well, I prefer the acute one, because the acute one reacts better and reacts faster on our treatment strategy. Unfortunately, most of the patients we see don't have an acute tenderness lesion, but they have a chronic tenderness lesion. Keep in mind that revalidation, recuperation of a chronic tenderness lesion takes more time. It could take several weeks more, it could take several months more, depending on the situation. Yeah? So keep that in mind. A resisted test could also be positive when there is a fracture. For instance, olecranon fracture. Somebody fell on his elbow. What are you going to find in the examination? A resisted elbow extension is not only going to be painful, but also weak, the combination of the two. Patella fracture, same situation, resisted extension, painful and weak. Of course, the clinical image is a little bit more elaborate than that, but this is one of the elements. Another situation. Let's imagine we do a resisted elbow extension, maximal isometrical. We ask to the patient, does that change anything? Remember, you don't ask, does it hurt? But does it change anything? And then the patient says, yeah, it hurts over here. That's strange. You do a resisted extension, so you test triceps, but you get pain over here, although the biceps is in a relaxed position. Is that something you expect or you don't expect? Well, let's think logically. You produce pain over there. Which dermatome is that? That's dermatome C5. So you produce C5 pain, so there should be somewhere a C5 origin. What can happen during resisted extension? You get more compression on the subdeltoid bursa, and if this patient has, by coincidence, a subdeltoid bursitis, thanks to this compression, you can provoke some C5 pain. Of course, the clinical image of a chronic bursitis in the shoulder is a typical image, is a clear image. I'm going to discuss that in one of the other films. But this is a clear example that a resisted test can compress an inert structure. And then finally, psychogenic patients, they love resisted tests. What do I mean by that? If you perform 2 resisted tests, if you perform 4, if you perform 6, they're always going to be positive. Psychogenic patient never says no on a resisted test. If you ask him, does that change anything? He says, yes. Not yes, not no, it's a combination of the two. But it's never really negative. So if every resisted test you get this type of answer, this is abnormal. First idea, psychogenic involvement. Fortunately, this is not so frequent. This is going to be a very important slide regarding interpretation. If a resisted test is painful but there is no weakness, then you think of a small lesion. Think of a small muscular lesion, a small tendinous lesion, muscle belly lesion, or a tendinitis or a tendinosis. This is my favorite combination. But it's also possible that during the resisted test you don't have pain. The resisted test is negative. The patient can have pain, but the test is negative, and you have weakness. Well, in that case, you think of a complete rupture. For instance, a complete rupture supraspinatus, your resisted abduction will be absolutely not painful, but 100% loss of force, total weakness. Or another option is a nervous lesion, for instance, a mononeuritis of the nervus suprascapularis, for instance, or compression, a lot of compression on a nerve root, on a C5 nerve root, hypothetically. The combination of a painful resisted test and weakness, this combination, that goes in the direction of a serious lesion. That goes in the direction of a fracture. That could also be heavy pathology, but the most obvious interpretation is going to be a partial rupture. Yeah? With a partial rupture, you always have the combination of pain and weakness. How partial is the rupture? That's something I don't know with my basic functional examination. Therefore, we need medical imaging to objectivate that. And as I mentioned before, the moment all resisted tests are positive, this is not acceptable anymore. Yeah, we think of a psychogenic problem or a hypersensitive patient or a problem that lies completely outside orthopedic medicine. Talking about weakness during a resisted test, as you saw earlier, could be related to a musculotendinous problem, yeah, total rupture, partial rupture. Could be related to a neurological problem, yeah, a specific nervous problem. But it could also be related to just simply pain. A nice example is a tennis elbow type 2. Yeah, a problem, an acute problem with extensor carpi radialis brevis. In the examination, you do resisted wrist extension. What happens in case of an acute tennis elbow? If you ask the patient to do this, you're going to have clear pain, but also clear weakness on the resisted test, not because there's a rupture, just because of the fact that, it's too painful. And another option is, but that happens with simulating patients, the patient simply doesn't want. You ask him to really do a contraction, but for some reason he refuses. No. This is not frequent, fortunately. So we may conclude, you do the functional examination, you have a series of positive tests, a series of negative tests. Okay. Your first question you ask yourself is, what did I see? Did I see a local lesion or did I see a referred problem? The patient with pain over here, is that a local problem or is it referred from cervical spine? How do you know that? You know that after the history. Yeah? And then after the functional examination, you ask yourself, okay, what did we see? An inert problem or a contractile problem? And if we saw an inert problem, capsular pattern, non-capsular pattern. Capsular pattern, arthrosis, arthritis. Non-capsular pattern, something else. Do I know at this moment which structure is responsible for the complaints? Possibly yes. Do I know where exactly? Possibly no. Perhaps I have a localizing sign. Remember one of the previous films? I have a localizing sign that points me in the direction of the specific part of a specific structure. But, well, sometimes I don't have a localizing sign. And then it's time for palpation. Remember, we never start an examination with palpation. But if we decide to palpate for tenderness, we always do it at the end of the examination. First, we determine the structure at fault. And then we do a specific palpation in that structure. Actually, how did Syriacs come to all those conclusions? Well, not only Syriacs, but many doctors. Well, an efficient system which is still valid today is the use of diagnostic infiltrations. A diagnostic infiltration with local anesthetic, with a procaine solution or a xylocaine solution. Let's imagine you have doubts. Is the problem an infraspinatus problem or is it a chronic bursitis? Yeah, sometimes clinical images may be more or less the same. That's subject for another film. So what do? You're going to do selective infiltration in one of the two structures, but selective infiltration. I'm not talking about bazooka infiltration. Yeah, it's selective infiltration. You wait a few minutes and you retest. And then you see what happened. Let's imagine you infiltrate the bursa and after a few minutes the painful arc completely disappeared. Okay, perfect. Then you continue on the bursa track. Let's imagine nothing changed, then you continue on the other track. We always try to work as logical and as objective as possible. For those of you who may not perform diagnostic infiltrations because of, for instance, legal reasons, well, then you have an alternative. Deep transverse friction massage, which is subject of another film, also has an anesthetic effect. Of course, you're not going to friction the bursa, but you can friction the supraspinatus or the infraspinatus. You do a test friction, 5 minutes of deep friction, then retest and see what happens. If there is a clear change, then you continue. If there is no change, then probably the structure you frictioned is not responsible for the complaints. And in this way, we're going to evaluate slowly but surely. So after all, we only have one purpose. We go for your success in orthopedic medicine. So, welcome back. What is the most important thing to remember from this film on examination techniques? Well, the basic functional examination is so important. Yeah? Don't focus on one positive test. A single positive test practically never has any meaning. We have to focus on the clusters of positive tests, the clusters of negative tests, so that you see the cohesion in the clinical examination. This image points in a certain direction and this image points in another direction. If your basic functional examination is negative, then you could proceed with some accessory tests. But keep in mind, when you do functional examination, always ask yourself the question, what am I testing? Am I testing what I think I'm testing? Yeah, that's very important. Are my tests, is the procedure relevant? So always keep that in mind. A good basic functional examination is the first step to more success in orthopedic medicine. So, if you have any further questions for me or suggestions, please feel free to use the live chat. But if you're watching this webinar in a replay mode, then just use the email function and send me an email, and I'm going to be happy to reply you. Well, the film you just saw is part of the online course in orthopedic medicine, the masterclass course in orthopedic medicine. And in this masterclass, we have about 68 different films on diagnosis, clinical reasoning, treatment strategy, treatment techniques. Have a look on learnorthopedicmedicine.com. And if you would like to sign in for the masterclass, you can do that on a monthly basis. Use the bonus code webinar, and then you're going to see you get an extra little surprise. So I hope this webinar was useful for you. I look forward to your questions and to seeing you next time on the next webinar. Thank you. Bye-bye.